Welcome to Activating Health Data to Achieve Health Equity, an event to drive strategies and solutions for race, ethnicity, and language, and sexual orientation and gender identity data, REAL and SOGI. Hopefully, we're all here to learn about how these demographic data can help meet stakeholder needs and why they are important to achieving health equity. We'll also hear from experts around best practices, promising strategies, and solutions when it comes to collecting, using, and sharing these data. My name is Josh Prasad. I'm at HRSA and lead innovation efforts, which is routed out of our Office of Planning, Analysis, and Evaluation. And that's why I'm so personally really excited to be here to be with this group of national leaders to talk about achieving equity through something like data. I'm moderating today's event with my colleague Shruti Kotari. She leads industry initiatives for Blue Shield of California. Shruti is going to be moderating the second half of today's event, so you're stuck with me here in the beginning for the lightning rounds. All too often, our data sharing infrastructure and surveillance systems have stymied the way we deliver public health. We're seeing this in our efforts to tackle COVID-19, for example. Even when data is being shared, it often lacks the key demographic pieces that are needed to tailor responses to ensure health equity. According to reports during the height of the vaccine rollout, for example, nearly half of all records shared with the federal government lacked race and ethnicity data. Similarly, sexual orientation and gender identity have gone unreported as well. We can't study, improve, and innovate upon what we don't know. And data plays this foundational role in improving community health and tackling the upstream drivers of inequity. As we improve our data, we can improve the way innovations and programs are funded and build a culture of partnership to ensure that they succeed. We hope that we can elevate the critical conversation around the need for better demographic data to prepare for the next public health emergency, or just meet the daily health needs of all who live in America.
So Jaime Bland, President and CEO of CyncHealth, and I'll do a quick introduction to CyncHealth, which is the statewide health information exchange and prescription monitoring program for the state of Nebraska, as well as the health information exchange for the state of Iowa. Next slide. So in those roles as statewide data organization, we have a number of data collection points. So whether that be hospital, clinic, pharmacies, public health data, we work across the ecosystem to connect organizations and share data. So prior to COVID, you can think about the care coordination activities that were happening, as well as moving data from different types of organizations like community settings into our public health partners. Between Nebraska and Iowa, we cover a large geographic footprint, as well as support communities from urban to rural to frontier locations. So we describe CyncHealth as a health data utility in that we fulfill multiple use cases. And because we connect to so many different types of organizations, one of our most utilized tools prior to COVID was demographic data, in that we would supplement data, whether that be from the Medicaid population to a provider having that information, the contact information, blending those records across multiple systems to ensure that we had really good demographic content and understanding both race, ethnicity, and other data collection points that were necessary for really providing the comprehensive longitudinal health record. Next slide. So from a health equity and health information exchange perspective, one thing that we have really understood from our healthcare delivery partners was that interoperability gaps disproportionately affect those that are caring for at-risk populations and vulnerable populations across the geography, whether that be urban, rural, or frontier, and academic medical center down to primary care practices and rural locations. So the effort to really connect and provide more connectivity to the communities, we started with the social care technology component in 2019, in which we leveraged workflow referral components, as well as started working with partners in 2-in-1 United Way to really understand how we could connect community to healthcare and healthcare to community. There had been several attempts previously to deploy technology in different healthcare systems. And how it ended up with the HIE is because we began to really understand that these siloed applications weren't really going to be utilized broadly unless we could provide some standardization in the community. We could rely on a tool, and that was best served in our organization in a neutral convener that was agnostic to healthcare delivery system, as well as the components around various access to technology. Next slide. So we had, going back into 2019, prior to COVID, we had a number of growing initiatives around community and healthcare systems. And this need for sharing of information across both community and into healthcare delivery system also brought its own governance challenges. How do we connect community data to public health data, to payer data? All of those things really convened in our organization, and is where we really started to understand what a health data utility could be and how that could encompass not only the health information exchange, but also the social care referral and information that are available in systems like our partner Unite Us. And with that, we were able to establish advisory councils and different community engagement activities, and leverage that information for beginning of social care referrals. And if we fast forward into, in the midst of COVID, what happened is that we were able to connect not only clinical information using the demographic data. So you think about, I got a lab test that needs to go to my provider. My lab test was from a mass testing site, or a lab that's not connected to my healthcare system. How does that data get back to my provider? So we were able to leverage not only the interoperability components, but then we were able to match that information longitudinally across time for the various lab tests that were taking place. And then, if we had social care that was connected to that, we're leveraging what's called the Enterprise Master Patient Index into various systems, so that we're able to connect both COVID positive to intervention to clinical outcome across time. And that's still work that we continue today. Next slide. This is just a little bit of a footprint in what we're looking for in the social care data exchange, and where we have a lot of robustness coming through in the various partnership with the community, as well as the referrals that are taking place. Again, this is a complex convening of both healthcare delivery and community, and involves partners like United Way 211, the FQHCs, providers, and a number of different community stakeholders. And technology is but one piece of the puzzle, right? It takes a lot of folks to be engaged around what we are trying to achieve by connecting the social care data with healthcare data, as well as the understanding that having a tool to understand where referrals are coming from, where they're going, and what we can do to tie that to outcome is definitely something that is novel. And we're starting to help community organizations understand outcomes in addition to their volume of work and the referral types. Next slide. So with that, that really is our comprehensive health information exchange, as well as the social care technology, and the work that we did around demographics, including REAL and SOGI, which is another place where we actually had to involve workflow changes and engagement of providers to ensure that we're gathering the right data so that we could connect the records across the ecosystem. Thank you.
Hello, good afternoon, everybody. My name is Kymie Thomas, and I am an enrolled member of the Navajo Nation. Thank you for attending today's session. I am the program lead for the Navajo Fruit and Vegetable Prescription Program, which is under the nonprofit organization, the COPE program. Next slide. So COPE is a nonprofit organization that is Native controlled, and our ultimate goal is seeking to eliminate health disparities and improve the well-being of American Indians and Alaska Natives. We believe that the power to overturn these long-standing historical health inequalities lies inherently by investing in the community, the Native communities themselves. By investing in these existing resources found in tribal communities, it is our hope that we are able to improve health outcomes among Native people and implement programs that are sufficient in helping us to deliver programs that are aimed at enhancing the quality of life for our Native people. The COPE program right now serves areas across the Navajo Nation, which includes areas found in Utah, Utah, New Mexico, and Arizona. Next slide, please. So data collection, with eliminating health disparities within tribal communities and enhancing health equity will require heightened emphasis on translating and the dissemination of data in tribal communities. With the Navajo FVRx program, our data collection is done through both quantitative and qualitative methods to address barriers found in food insecurity, chronic diseases, and as well as the overall impact of the program. How do we know that the program that we're implementing to our community members is actually working? That is done through a multidisciplinary approach, data collection from our clinical sites to our home-based services, all the way to our program itself. The COPE program also includes dissemination practices to tribal leaders, healthcare providers across Navajo area, IHS, and our 638 health centers that are found on the Navajo Nation. And as part of this combined effort to combat the health disparities that our community members see, we also involve a lot of the community input and a lot of the community strengths that are found within the tribal reservation areas. And so by this multidisciplinary approach, we are able to really combat some of the shortcomings that we face with data collection on tribal nations. Data collection, as really a lot of us have barriers within data collection in itself, and ours particularly is pretty unique because we're still impacted by the lack of technology and the remote areas that some of our clinics are based in. And so we've had to modify our data collection practices and find ways to make it available for every health clinic that we work with. And so COPE currently uses the ComCare platform, which is a data collection platform that is operable with minimal internet connectivity and results in real-time data submission into the cloud, which we then are able to extract and see, the overall impact, what are some of these shortcomings that we see within the communities and the patients that we serve. By transitioning from our electronic data collection, we were able to develop community programs that are tailored to address community needs. And that's really the emphasis that COPE plays, in helping us to understand how the data works, how we're able to, translate it in a way that not only it makes sense to us as, public health people, healthcare providers, but really engaging the involvement of the community and helping us to help them understand, where some of the shortcomings are regarding, stores, clinic access, and, things like that. Next slide. And, with the whole thing with identifying a need, that's how we were able to develop a program, particularly the Navajo FVRx program, with the high rates of chronic diseases on the Navajo Nation, the high rates of food insecurity would have also been, exacerbated by COVID. We were able to develop a program and, ultimately see how this program is going to be beneficial to the people, how, we can really incorporate a lot of the data that we see from the healthcare providers who are seeing these patients, and then really tailor the program to each unique clinic. And that's the great thing about our program is that, across the Navajo Nation, we have clinics that, operate and implement our program in a way that is, unique to each and every one of them. And just based on the data that we see from the clinics in the different regions of the Navajo Nation, we really look into helping us to streamline the data that we see and, disseminate that back to the providers, again, and to our tribal leaders, to show them that, these interventions are working, that they are really enhancing health outcomes among our people, and by involving more community members and the tribal leadership, and investing in what resources that we currently have, we're able to develop a model that is effective on our Navajo Nation. Hopefully, in the next couple of years, or in the next in the future, we're able to I guess replicate this model that we see across all tribal communities, because each tribal community is unique, but really taking this program and helping other communities implement it, I think would be very, very effective. And so really the data component of it is so important. And tribal communities have also really, the structure of data collection is challenging across the board, because some of that information that is collected really isn't distributed back to the clinics. And so as a Native person, a Native community member, I would like to see more of that data really implemented and shown back to the people, and to kind of see where some of the shortcomings are within our healthcare access, improving health equity across all tribal communities. Next slide, please. And that is it. And I wish I had more time to talk a little bit more about the data collection practices in our community program.
Thank you. Good morning. It's morning in California, so let's say good morning. And just starting with this first slide, I will say that I am the Executive Director of the Department of Homelessness and Supportive Housing, but what I'm going to be talking about today is really mostly work that I did when I was the Director of the Department of Disability and Aging in San Francisco. Next slide. So I wanted to start by saying that I'm going to talk a little bit about some work that our department did with the LGBTQ plus community of older adults in San Francisco. And just want to start with this slide by saying that the impetus for change always comes from people who are experiencing inequities in our systems. We don't know what's needed to achieve equity unless we truly center this experience. So in the city, LGBTQ older adults have been advocating for inclusion and equity for many years. They caught the ear of some board members at our Board of Supervisors, and in 2012, the LGBTQ Aging Policy Task Force was born. The role of the task force was to advise the board on matters relating to the needs and concerns of senior members of the community. Each appointee on the task force is a member of the community, of the LGBTQ plus community. The task force held hearings and took testimony regarding LGBT senior issues. And they also worked with a consultant and produced a report that made recommendations on issues from data collection, cultural competency, health and social services, and housing. One of their main concerns was that lack of data on gender equity, gender identity, and sexual orientation among city agencies prevented the understanding of service needs and utilization within the population. Next slide. So the city began to require departments to collect SOGI data. They did that in 2016, and the Department of Disability and Aging was one of the first departments to begin the collection. Preparing for this meant a real communication strategy with our team, both our internal staff and community partners, and really clear messaging from me and the rest of our leadership to staff and all of our community partners, saying like, this is what we're going to be doing. And we need people to really understand why, and we need people to really understand how to collect this information, how to do it without judgment, how to really make sure that it's part of our regular questions about demographics in general, and to really make sure that people understood the point which is it's inclusion, but it's also really to get data that allows us to make better decisions. And then in 2017, after we had collected a full year of data, our department did look at our key findings and kind of did a deep dive equity analysis into the experiences of LGBTQ plus seniors in our system. We noticed after a full year that the data collection had significantly improved. At first, the collection was really sparse and people didn't really take it seriously, but we kept on it and it got a lot better. we noticed that compared to all program participants, the clients identifying as LGBTQ+ were more likely to be white and to live alone. And we realized that LGBTQ seniors were 2.5 times less likely to utilize services. While that varied by program, they access services housed within LGBTQ identified agencies at a higher rate, but didn't really go for what we called the mainstream services. And so from that, we were able to create a new strategy to really engage communities in a different way. Communities of color identifying as LGBTQ, really working with them to figure out how we could fix some of the gaps in programming, and how we could better make people feel inclusive in our regular and not regular, but mainstream programming. And then we also realized that there was the transgender nonconforming and gender nonconforming community that was even using our programs at a lesser rate. And so we were able to work with those communities to do a better job. So the data collection really helped us kind of get to some of the core issues that we had and be able to engage in the community in a different way. Next slide. So what we found in that first deep dive was that people were underrepresented. We realized that, providing services specifically for LGBTQ people continue to be very important. We realized that we needed to do more training, even, double down on the training with staff and community partners to make sure that organizations really had the tools to be inclusive, welcoming, and confirming. And then we also realized, and I'm just going to switch over to the Department of Homelessness for a minute. When we did our gender LGBTQ demographic collection in this department, we realized that trans and gender nonconforming people are much more likely to experience homelessness in our system. And so we've been really able to work with the trans community in San Francisco to begin a 2-year plan to get to functional zero for trans and gender nonconforming homelessness. And that's because the numbers are very small and there are barriers that we can actually really address now that we've begun to work with the community. And then just to go to the last slide. So the key takeaways really are centering the experience of people at the center of any work that you do, and have that experience guide everything that you do, all the planning, all the strategy, all the training. There's real importance of messaging from leadership about communication and transparency, making sure that everybody understands what the message is and why we're trying to make change in our system. Training is really essential. In-person training for this particular topic was really important. Role playing and all those things. If you're not getting the information you need, you're not getting the data, keep trying and keep talking about why it's important, and making sure that you're really monitoring to that. And then there's just a real obligation to use the data to make real and sustained change. And I say that because so often we collect this data and then don't really use it in the most effective ways that we can. And so just a reminder that that's why we're doing it, and we need to use it to better our services. And I think that is the end of my time. Thank you very much.
Thanks so much, Shireen. I like your point there, just that we got to use our data for something real and meaningful. I think that's why we're all here today. So I want to thank all of you, all of our lightning round speakers, for sharing your stories about your organizations and your work. I want to hand it over now to Shruti, who will be moderating our panel discussion.
Amazing. Thank you, Josh. I am so excited to be here. Those were some incredible lightning round presentations, and I think really set the stage for our next discussion, which is our featured panel. Again, my name is Shruti Katari, and I lead industry initiatives for Blue Shield of California. So we are really focused on healthcare transformation through industry collaboration. And today we have a truly amazing group of panelists for you today. And we'll get to introductions in just a minute. But what we're going to be discussing is why REAL and SOGI data are important for health equity and what we should be considering as we develop strategies and solutions around collecting, sharing, and using that data. And so our earlier presentations were a great set of use cases and specific examples. And we're going to dive into more discussion around it and provide more examples for you all. So at this time, I'd love to have our panelists join me on camera. We'll wait till we all get there. Perfect. Amazing. I said we have a group of pretty amazing people on this panel, and it is very true. We have Andy Slavith, who is a former Biden White House senior advisor, also the past head of Medicare and Medicaid during the Obama administration, author of Preventable, and I'm sure you've seen him on Twitter and listened to his podcast In the Bubble. We have Lynn Chow O'Keefe, who is the founder and managing partner of Define Ventures. Naomi Senkito, who's the Managing Director of Health Equity for Blue Cross Blue Shield Association, and Dr. Sandra Hernandez, President and CEO of the California Healthcare Foundation, which Andy earlier said, also known as Rockstar. So it is very true. We're very excited to have you guys here today. Thank you for taking the time. And the fact that you all are here to discuss this very topic just demonstrates, just the importance and all the eyes and folks that are on this. And so, we've heard from the lightning round panelists about how REAL and SOGI data can be used to help drive changes for service programs and for care delivery. To start our conversation, we're gonna go into that as well. But to start our conversation, would love for you all to introduce yourselves a bit more. And really, you all are funders and financiers in healthcare, and we really specifically wanted your perspective of that funding and financing. And so, if you can touch upon why the collection and aggregation of demographic data, specifically REAL and SOGI data, are important for your work in your intros, would love to hear about that. So Dr. Hernandez, let's start with you.
Thank you. Good morning. It's nice good morning from California, at least. It's nice to be with you. I'm the president and CEO of the California Healthcare Foundation. We're a statewide independent foundation really trying to improve the delivery of healthcare for all Californians, but with a particular focus on folks who are low income. And in California, of course, that includes about 14 million Californians that are enrolled in our Medi-Cal program, our Medicaid program in California. And so a lot of the work that CHCS does is really trying to address health equity as it relates to folks that are enrolled in that particular program. I love the panel presentation earlier. I would take away the highlight that the lack of interoperability is a health equity and disparity issue itself. I think as we think about the California and the 40 million people that live here, we sort of aspire to do what Jaime talked about having done in Nebraska, right? Which is really to create a data infrastructure capability in the state that sort of takes us from a number of different silos where a little bit of data is captured here, a little bit of data is shared in a particular network, but really we don't have a framework for how data ought to be collected, what the data elements are. And of course, if you don't have that kind of information, you have great inefficiencies in the system, you have great redundancies in the system, and perhaps most importantly of all, you're not able to actually see the disparities that are at play when you're looking at any particular population or any particular outcome. And that really is a situation we find ourselves in California, and we have enormous opportunities to improve that. So one of the pieces of work that CHCF is involved in is really helping the state think about a governance structure by which a framework for racial data, LGBTQ data, all the different categories, language capabilities, cultural competencies, status of housing situations, all of that information could get collected and shared with an interoperable framework. In California, that's being discussed today as a governance challenge. There's a desire to sort of have everybody at the table. And I think one of the things that we recognize is there are very good models where you have consumers and folks who need to be able to trust the data that gets put into systems at the table to help you govern that data. CHCF also runs an innovation fund. Lynn's very familiar with it. And that fund is really meant to identify entrepreneurs who have lived experiences with social determinants, see opportunities to address those through technology. And CHCF does investments in those companies to help bring them to scale within the Medi-Cal program. And I'm sure Lynn will talk more about that. And then finally, I would just say, as we think about the delivery system and you look at outcomes, whether you look at it through California Health Exchange, our Covered California program, or you look at it through the Medicaid program, we recognize that the delivery system looks up at many, many, many different metrics to try to aim at improvements. And one of the exciting things that's happening in California today that CHCF is trying to support is to have our public purchasers align around both key data that's collected in our systems, but importantly also that it has key metrics that it's aiming at improving. And we're working very aggressively to support those efforts as we think about really moving into a system much like Jaime described. So I'll stop there and let others jump in, and happy to take any questions later. Thank you, Shireen.
Thank you. It's good to be with everybody. A really important conversation today, a really important topic, and I think you'll probably find a lot of us in this panel suggesting that there's big tailwinds towards the work that you all are doing if you are involved in making sure we collect and have this data available. Let me just give you two quick anecdotes. I served in the White House for the first 4 months of the year, and the first presentation we made to President Biden and Vice President Harris was on the topic of health equity, and we were eager to report what the take-up rate of vaccines were by community group and by racial and ethnic segment. And we had and have a full-time panel, as many of you know, on health equity, driven by the White House. We were doing all the work on it, and we expected there to be a gap between take-up rates between racial minorities and white populations. So as we presented the data to the president and vice president, the thing that stood out the most was not the difference between white and minority populations so much as the 50% unknown bucket. And if you ever try presenting a piece of information to the president and vice president and say, we don't have half the data, and they're not healthcare people, so they're not steeped in the same stuff we're all steeped in. And so they said, why? And you're like, well, that has about a 10-year-old answer. It has about a 50-year-old answer. And of course, they were unhappy with our lack of visibility as a country. And I think, everyone tried to explain why this was sort of a significant endemic problem that we had, that we couldn't even report on this. At the end of the day, as I think many of you know, thanks in large part to a lot of the people that are probably on this call, we ended up closing what was initially a 10 to 15 point equity gap in vaccinations. But to do that, we had to do very specific things. We had to, the first time we opened up a massive vaccination center was when we opened up in Oakland and when we opened up in East Los Angeles. In the first day that the vaccines were available, guess who showed up at those vaccination sites? If you guessed people from San Francisco and Beverly Hills, you'd be exactly correct. Maybe people making their first trip to Oakland or East Los Angeles in a long, long, long time, perhaps. But it was seeing that first day that called on us to basically say, hey, look, we are going to have to reserve many hours of the day, including before and after working hours, solely for people who live in these zip codes. And to require that CVS and Walgreens and Walmart and everybody else report to us publicly the amount of the vaccine shots that were going to people based on race and other categories. So this was I obviously kind of a moment where we didn't have systems in place, and we got what the healthcare system was able to already produce, and we had to run fast. But I think when we look at public health, emergencies, crises, as one use case, we all know that the disparities result in very quick, painful outcomes. This isn't the kind of stuff you see over decades. This kind of thing you see oftentimes over days and weeks, where people are dying at much more rapid paces in certain communities. So identifying it's the first step, getting people to care is the next step, and that's one use case. Secondly, I'll just relate a conversation that I've had, and I'm sure many of you have had over conversations with, whether it's Chiquita Brooks Ashore or Mina Sishamani or Liz Fowler. Their the requirements to participate in value-based care models are going to depend upon a demonstration of delivering equitable health results. Now, they still have, as people may know, a comment period outstanding, and they're still looking for ideas. But I can tell you from my time at CMS, this is where things sprout. You get the regulation done reasonably right. There's no way to perfect it. And that will create a set of requirements, which will create a set of needs, which should spark some type of action here. And so this is the most clear signal and market force we often see in healthcare, is when CMS decides, hey, we're going to do something, we're going to require something. And if you're going to get a STARS payment in the future, if you're going to get a value-based care payment in the future, if you're going to participate in our programs in the future, you're going to have to do this demonstration. I used to ask, when I was CMS administrator, whenever I would visit a hospital system, I would always start with the same question. Don't tell me about your triple aim. I'm sure I'm going to hear a big speech about your triple aim. Tell me about the difference between the care delivered to the top 10% of your population and the bottom 10% in terms of income and in terms of results. Tell me how wide that gap is, and tell me how you're going to close it. Now, I start the conversation that way because I knew they didn't have the data. Nobody had an answer. And so don't ever let anybody tell you they're committed to health equity if they can't give you an answer, and they can't say what the starting point is, and how they're going to close the gap. That's all I got.
That was a lot, and amazing a lot. Can't agree more on many of your comments, but your comments about value-based payment models, that's something that we are very focused on at Blue Shield of California. Check out the chat. We actually wrote a white paper on exactly what you were talking about, Andy, in terms of how value-based payment models do support equity and access, especially in primary care. Next, why don't we hear from Naomi from the health plan as a funder perspective?
Thank you, Shruti. I'm so excited to participate in this panel on such an important topic, and to hear from the other panelists. As Shruti said, I am Naomi Sanquito, Managing Director for Health Equity Policy at the Blue Cross Blue Shield Association, also known as BCBSA, so you'll hear me say that. And in this role, I lead our policy and strategy development on addressing health disparities and equity through legislative and regulatory policy, both at the federal and state levels. As many folks may know, last April, BCBSA launched our National Health Equity Strategy, which is focused on changing the trajectory of health disparities in this country and reimagining a more equitable healthcare system for all. Across the country, every Blue Cross Blue Shield plan, including Blue Shield of California, and in Puerto Rico, have launched local initiatives to address health disparities, with across the system over more than 300 programs already in place, and that has existed for quite some time. Our National Health Equity Strategy is an ongoing commitment to improving outcomes for communities of color, recognizing that while across the Blue Cross Blue Shield system, we've made many great strides in advancing equity in our local communities, there's so much more to be done. And the lightning round panelists talked a great deal about this. The key to that is ensuring that we have complete and accurate demographic data, including race, ethnicity, and language data, sexual orientation, and gender identity data, which we at BCBSA believe is really foundational to identifying disparities in healthcare and outcomes, as well as monitoring and evaluating the effectiveness of interventions and initiatives. Josh noted this in his introduction, and a couple of the opening panelists also said this as well. But as the old adage goes, you can't improve what you do not measure. And so really at core, you can't. We can implement, interventions and initiatives and programs, but unless we're able to evaluate them and monitor the progress that's being made, you really aren't, to Andy's point, you can't really justify and explain how you're, closing the gap there. So the commitment, to advancing equity really starts with the foundation of establishing, having complete and accurate demographic data.
Thank you, Naomi. Appreciate that. And last but certainly not least, Lynn.
Well, it's great to be here. Thank you so much. And great to be with such friends here. Quite frankly, we all have intersected in so many ways. I think how we think about it, and I should, contextualize again, the angle that I'm kind of coming from is the founding and managing partner of Defined Ventures. We invest in early stage digital health companies from incubation to Series B. So really try to unlock this question of data. And I think, a general framework that I've always used if I was investing in enterprise software companies or digital health companies is really simplistic. We need data to drive insights to then drive action. And it's those three categories that we've thought over time. Back in 2018, when we established Defined Ventures, we really thought about dark data sets, of which what we're talking about is one of those. So really happy about some of the partnerships that we've made of startups that are trying to progress in this field. And that would have intersected with CHCF and Andy Slavitt's town hall as well, which is Unite Us, which is a classic example of gathering the data so that those can drive insights for providers and payers around, again, community-based health, SDOH. So that was one of our first bets here at Defined Ventures in early 2019. But I also want to push on a different way of thinking as well, in that it's not always that it goes data, insights to action. Sometimes you have to create, on the action layer to then actually drive back to data. And what I mean by that is at Defined Ventures, we've also created very customized healthcare solutions for certain demographics of the population in order to understand them more and drive more valuable and rich data back again. So what do I mean by that? We've incubated a company called Folks Health, which addresses the LGBTQ population. We did that back in 2019, which we're very proud of. And because of the really customized solution set that we've provided this population has actually told us what other products and services they want as we build out our product development pipeline and map. The other companies that we've also partnered with are companies like TIA and women's health as well. So sometimes what I say too is, and I'm sure we'll get into this, we're going to create those action layers to then drive back data and insights. But great to be here, Shruti. Thank you so much, and looking forward to this discussion.
Yes, thank you all for being here. We've already started diving into some of the conversation, and you've all already provided a little bit of use cases and examples, but let's elaborate on some of that for our next question. Would love to chat about, how can this data, the REAL and SOGI data, be used to tackle health disparities? And specifically, how can it improve health and public health? And if you have more specific examples to share, we would love to hear it. And Lynn, I know we just ended with you, but maybe we can start with you.
Yeah, we've really tackled this. Again, I'm going to use all these like euphemisms I hate to say is, how do we drive trust? And I think this is the overall kind of how we think at Defined Ventures is really integrating a consumer approach with healthcare and technology in order to create solution sets. And we've always come at it of how do we drive trust and understanding to then kind of drive the solution set, as I said before. So I think as we thought about these health inequities, we're attacking this in a multi-pronged way. There's the data layer, which we've talked about, Unite Us. There's kind of the insight layer. We actually have another company that we've partnered with called Soda Health, which is actually creating insights and benefit structures for the population to drive things in SDOH layer like transportation and food security as an example. And then kind of this action layer, which is a full suite of services that we see go forward. So we think it's this multi pronged solution, but what we're trying to get at the heart of this is how do we drive that trust to then drive other actions and to drive, again, these benefits and values. And I think a couple things that we think about when we drive trust is authenticity of voice, right? Really, and that's led us to create companies in a direct-to-consumer fashion. And I know this is maybe a little antithetical to a lot of people on the call. We're not going through an employer. We're not going through a payer. We're actually not even going through a provider. We're actually going straight to this community in a direct-to-consumer fashion, building these solution sets, and then arcing our way back into what I'll call healthcare with a big H, the enterprise level. And so that authenticity of voice is important. It also drives our actual clinician layer. So in Folks Health, we went direct to consumer to establish that trust and that voice. And then all of our clinicians that we've hired and on the platform are from that community as well. And then we're driving specific solution sets for that community. So hopefully you hear, again, trust, authenticity of voice, clinicians who can really understand this community, and a solution set of services that really address what the community needs going forward.
Yeah, that makes a lot of sense. And I would imagine, I know Dr. Hernandez and Lynn, you work closely together at the Innovation Fund, but also you're a funder in so many other ways. So we'd love to hear from you next.
Well, sure. Maybe I'll just pick up on what Andy was getting at. So as I mentioned, our Medi-Cal program, so here we are, we're working in the big public purchasing arena in California. And the state put forward a number of waivers to CMS that really, I would argue, is sort of a once in a 40-year, 50-year transformation effort of the Medi-Cal program in California, so-called CalAIM. And really what CalAIM does is really try to take a delivery system that fragments mental health, behavioral health, substance use disorder, physical health, primary care. We're a state that has 58 different counties. Counties have the responsibility in California to take care of people with serious mental illness. The vast majority of people in Medi-Cal are in managed care plans that are often county plans, but often also regional in nature. And so in order to be successful at this grand experiment of innovating in Medi-Cal and really doing intensive care coordination, intensive behavioral health integration with primary care, you really can't do any of those successfully without having a data infrastructure as a backbone and a pillar to that work. And so what CHCS does in that space is really try to identify all of the data sharing that currently exists, because California did this whole person care work, again, with CMS's blessing, to begin to prepare for CalAIM. And what we did as a foundation was really try to understand where the data sharing gaps were, to identify those gaps and to begin to name them, so that as CalAIM came online and will over the next 2 and 3 and 4 years, we understand what those data elements are that are necessary. You know, we talk about sort of disparities, and in California, as in many urban centers, we have an enormous homeless population. And we have great programs, as Lynn mentioned, that are doing incredibly useful things around trying to understand where a homeless individual or someone who's unsheltered chronically or episodically, how do they interface with the healthcare system? What are their needs? How do we make sure that they get both housing and healthcare and their behavioral health needs met? And really, you can't do that unless you have data that readily shares across these systems. So the work that we have been doing in CalAIM is both to shine lights on where there are gaps, understand where it has worked to connect that data, and then really try to push the state to stand up a data exchange framework that will allow the CMS waivers that have been approved to really significantly address people with multiple chronic conditions, comorbid conditions, and folks that we know today interface with our healthcare system in a really discoordinated and haphazard way. And of course, with very negative health disparities associated with those. So that's just a really concrete case example of where CHCF sort of works at the seams of both our not-for-profits, our community-based organizations, our health plans, and increasingly, of course, our delivery system and our counties to begin to do this work. I mean, Andy talked about COVID and standing up the Oakland test site here. I'm standing in Oakland today, and I'll just tell you that the public health link to the physical health delivery system, likewise in this work around CalAIM, where we're really trying to also promote wellness and prevention programs, also require that public health data with physical health data be totally interoperable, and that we collect the necessary data such that you can disaggregate it and use that data to modify programs as you move forward.
Well, first, in terms of, your question on, how data can tackle health disparities, I did just want to give a sense of, again, kind of bringing it back to BCBSA's National Health Equity Strategy, how we view data being so important to tackling health disparities. And then I'll give a specific example that I think is a great example of how data is being used, but then also, how, one of our plans are doing partnerships with external stakeholders. So for BCBSA, having access to accurate and complete data and greater standardization of that data is critical. From our perspective, it will allow health plans to more accurately quantify health disparities that exist so we can address them more directly, like with targeted interventions. And specifically, it also will allow us to tailor interventions and programming towards specific communities and people in a timely manner, right? So you want to make sure that, I know a couple of speakers earlier had talked about centering communities in the work to advance equity. And so you want to make sure that the interventions that are targeted to communities are timely and meeting the needs at the time. As well, data will allow us to actively lean into new and longstanding relationships with community organizations to help address specific root causes of the inequities. And then, of course, in my space, enable us to advocate for public policies at the state and federal levels to address disparities and advance equity. So one great example of a Blue Cross Blue Shield plan utilizing demographic data to tailor timely interventions is the collaboration that was announced in late 2020 between Blue Cross Blue Shield of Tennessee and Meharry Medical College. And that collaboration is aimed at utilizing data to help overcome vaccine hesitancy and promote hope and healing from COVID-19. So along this, COVID-19, we heard from Dr. Hernandez and Andy specifically, some examples there. But this approach, the partnership between the Tennessee plan and Meharry Medical College, their approach is really driven by the recognition that existing initiatives on overcoming vaccine hesitancy tended to only look at individual beliefs and attitudes around vaccines, but never really took into account social determinants of health and community level factors. So for this partnership, in addition to looking at de-identified claims data on patients' prior refusal to accept vaccines, researchers also utilize the data to determine individual and population level factors that drive hesitancy related to vaccines in order to subsequently develop strategies and tailor interventions to address these factors and help build vaccine trust in communities. Another aim in this effort is to also provide resource allocation recommendations to public health officials and policymakers. So making sure that the resources that are available, with all of the COVID funding that had been flowing, over the years, was really going to the right place, right? Like not just, providing funds in spaces where, it wasn't necessarily having the impact. And so when they launched this collaboration, both leadership from the Tennessee Plan and Meharry Medical College noted how essential data is to identifying the factors that drive vaccine hesitancy, while also subsequently helping researchers, health plans, policymakers, and other stakeholders create more precise programs to meet the needs of our communities. One thing I'll note about this, this focus on COVID vaccines and hesitancy, it is just the first phase of this, longstanding partnership, this ongoing partnership between the Tennessee Plan and Meharry Medical College. But the data collaboration, will continue beyond COVID to really inform on gaps in care, particularly around socially vulnerable areas. And so as I was kind of preparing for this presentation, I was trying to think of one where it draws in the importance, one example that, draws in the importance of data, but then also brings in the importance of cross-stakeholder collaboration and partnerships, from researchers to health plans, payers, and such.
Jaime Bland, earlier touched upon the challenges of CyncHealth and as they faced in aligning the social care data with HIE efforts, and really just that community engagement. And so as you all see it, and from your seats and the work that you do, what are some of the gaps and needs when it comes to collecting and using REAL and SOGI data? And really, who should be collecting this data, and what are the key considerations? And Andy, we have not heard from you in a while, so let's start with you.
Yeah, well, look, I'm certainly not going to be the expert on this call in all those factors, but I would say, the highest level, we have a, Lynn, I think, spoke very appropriately about trust. And, there's a bunch of things we want to do that we don't think we can do to get to outcomes unless we have data and information on people. At some point, though, we are dealing with people that are very, very suspicious for good reason of the healthcare system. That's something we've earned, all of us, over decades of mistreatment, of ignoring people, of not acting in their best interests, and oftentimes of trying to do things that we think are good for them, but we're really doing to them. So I think there is a broader burden obligation to be made here. The burden of proof to saying, look, we have this great program and it's going to help you, starts out with oftentimes, if not implemented well, or if not explained well, or not described well, or quite frankly, if just divorced from the reality of implementation. In other words, we're going to spend 3 years collecting information and we're not going to see a benefit in the community the real people are going to feel for 5 or 6 years. It's rough. And so I think, if we had people on this call who I think, like Sandra has done, is collected people who have lived experience, and so you get a bunch of very smart people talking about collecting information about you. They'd say, well, those people sound like they mean well, but what's the fundamental gap they're going to close for me? And I think when Lynn talks about building trust, the way people, in her communities, whether it's folks or any of the other companies, when you're dealing with people that have an experience like theirs, when they can use the information that they're collecting to someone's benefit, and they can see that real benefit. We're involved in a similar company to folks called Plume Health, which is the largest provider of services to the trans community, and the largest number of providers that are trans providers that are trans friendly, providing gender affirming care. I think I don't think they talk about collecting data. They talk about building community. They talk about supporting people. They talk about helping people. And if you came and said, look, we've got larger policy aims here that are built around collecting and understanding data, I think they'd understand it on the one level. On the other hand, I think they'd say, our folks here that we serve every day, that's got to be its secondary importance or at best, because they show up in a system that doesn't understand them, doesn't even understand their name, doesn't understand their pronouns, doesn't understand who they are, and that's fundamentally disrespectful. So, if you're going to take a population and you're going to understand them, and you're going to start asking them to tell you their, for example, their gender identity, who's going to ask that question? What are they going to ask them? What are the choices they're going to give them? So you start off on the wrong foot there. I think you never get there. And so, as everybody in this call has said, it's not a virtual idea, but the people have to be in the room doing the work, as Sandra has pioneered, to begin the process, include people in the process, help people design the process, and have them talk to folks in their community in the process. I don't know any other way to do this in a way that I think feels like it has fidelity.
I think when we say we need data, and I love one of the chat comments, because this is exactly how we think about it at Define, is healthcare is traditionally very inside out. We need this data, and now let's like throw it over the transom to the consumer or patient here and just expect that they'll give it to us. And maybe we do it via a provider or a payer. And instead, how we think about it is very outside in, as you can see, right? If we can build that trust with those patients, those individuals, then what else would they give us to help shape the healthcare ecosystem that truly is fit for them? I think how we think about that, we've talked about trust, authenticity of voice, providers that have their lived experience of this community, but also going out to the nodes of the community that already have the trust. So we've seen startups go to the barber shops, go to the churches, right? I'm sure we've all had those conversations. And how can we enable those individuals to then kind of, I'd say, earn the right to then link to what I call healthcare aspects. But sometimes also what we think about is, what does someone need every day? And Sandra's going to laugh as I said this, because I just said this at the CHCF board. We've also thought about it, and I'll go back to this company, Soda Health, that I mentioned. We're actually, one of our driving theses is we're going to enable those who need in the population, like food security being one of them. We're actually giving them a card that they can go to Walmart, they can go and actually, receive fresh fruits and vegetables as an example. And why do we like that? And so we think about different things here at Define. We think about engagement curves. If we're going to build trust, how are we in front of them? And it's a very much a healthcare decision, but it might not feel that way to them. And as we've said, most people need to eat at least once a day, hopefully, and that we then get that rhythm where we build their trust every day because we're giving them that food security, right? And then we earn the right, and we have that authenticity of voice to then say, what else do you need? Or can we now connect? We've noticed this. Can we now connect you with someone who could help you in the community, or, go into what we'll call like healthy interventions? So we're always kind of thinking about it from the patient consumer point of view. And then how do we then link back to the system?
So I think this conversation about trust is super important. And Andy named correctly that our delivery system has done many things to not have folks that particularly struggle with good access and good outcomes. The way they're treated, what they're listened to, when they're listened to, how they're listened to. And yet we have within our delivery system, if you think about team-based care, promotores and community health workers who by definition live in these communities, are neighbors in these communities, know the language, know what people eat, know when somebody hasn't come out of their house for 3 days or 4 days. And tapping that as an asset of our teams, such that they already have the trust of the folks that we are trying to reach and of the folks that have the broadest social determinant of health disparities. And what we haven't done, of course, is finance them into our delivery system in a way that they're not just living grant to grant. And so one of the key things that came out of COVID-19 and the CARES Act was a realization that you needed exactly those people to be able to set up these programs, whether it was at the BART station in San Francisco or in some of the areas of East LA. And so one of the pieces of work that we think is so important is making sure that those promotores become part of team-based care. and that the information and knowledge that they have about community is formalized in a way that helps us meet these needs as a system, but also doesn't sort of take away the trust that they have spent so many years engendering within the communities themselves. So I think part of what we have to do is think about where, as Lynn was saying, where trust already exists or where it has been built, and use that as a way to begin to engage folks on their own terms, in their own language, based on how they prioritize their day-to-day needs. And I think when the system does that better, we'll have a much better likelihood of addressing some of these social determinants of health that we've been talking about.
I had a call about a month ago to go speak to a series as well. There's a set of investors and pharma company executives and biotech executives that were desperate to have a conversation. They said they had a really important topic on their mind. And when I got on to the Zoom, they said, we have one question. How can we convince people to give us their genome data? And I said, oh, that won't be a problem at all. Can I have your genome data, please? And they all just said, I said, how many of you are willing to give me your genome data right now? Well, what are you going to do with it? Blah, blah. I'm like, you know, I'll do really good things with it. I promise. I'll handle it with care. But they wanted to talk. They're going to wage a campaign that they think is going to somehow convince people to share their genomic data with them because they believe they can solve all the world's mysteries with it. Maybe they can. And look, we certainly don't want communities that are to be underrepresented from research. That's a big issue with clinical trials, as we all know. But we need a strategy to head this, either head this off or head this on. But to face up to this, because it's going to be where medicine is going to be over the next couple decades.
Absolutely, Andy. And you bring up a great point of also, right, players in the ecosystem that, and it's been brought up throughout this question, of players in the ecosystem that don't traditionally have that trust with folks, right? And how do you build that when you do have good intentions? And just to conclude this question, Naomi would actually love to hear health plans. Obviously, you know, let's just call it out as elephant in the room in terms of that trust, and may or may not have it with folks. What are your thoughts on this question?
Yeah, I mean, I echo what everyone else said on trust. I mean, I think that that's core, right? I mean, we can kind of establish questionnaires and processes and procedures to collect it, but without that trust, I mean, you know, we'll end up collecting data that's not accurate, right? And I do think, you know, and this, again, just echoing what everyone else said, adding to that, collectively, I think we do need to be more thoughtful and intentional around, you know, how we engage consumers, how we explain to them why the data is important, but as well, you know, how such data will act, like making the connection between data and how it actually addresses health disparities and how it would actually, you know, move the needle to advancing equity. I did kind of want to get a little policy wonky for a second. I do think the trust is really core, but I think there are other gaps that I didn't want to leave this conversation without sharing. Really quickly, you know, just across stakeholders, including providers and payers, you know, as you know, we don't have access to consistent and quality demographic data. A lot of that is due to overlapping federal and state laws governing various aspects of data collection and use. You know, from a health plan perspective, in particular, there are some states that are, you know, in some states, health plans are subject to state laws expressly prohibiting the collection of race and ethnicity data. And in some cases, you know, in a handful of states, the laws around the collection are specific to, you know, enrollment in health insurance, right? And so, you know, from a health plan, that's how we would probably, you know, if we wanted to collect the data, that's the first line of, like, you know, you're trying to enroll in coverage. And so, you know, it would be part of the questionnaire, but there are a handful of states that expressly prohibit that, right? And so those are some of the kind of federal and state challenges. You know, at the federal level, you know, there's issues around, but both the federal and state level, there are, you know, different regulations governing data privacy. So at the federal level, it's HIPAA. at the state level, there are various individual state laws around privacy, around the data standards. So, and a lot of those laws vary from state to state, as other laws do. So those are some of the gaps right there, where it's the kind of overlapping, in some cases conflicting, federal and state laws and regulations that also need to be part of this conversation around that's collective standardization around the collection, the use of REL and SOGI data.
So I'm reading off my phone from questions from our audience. Thank you for submitting and keep submitting. So the first question is for Director McSpadden and Kymie. We received several questions about establishing trust. Great segue from our last question of the panel, with providers and members for collecting sensitive data. How were you able to ensure that people felt comfortable sharing REAL and SOGI data? And what steps did your organization take to engage with community members and build trust? If you can give some specific examples.
Thank you for the question. And, I started by saying that we can't make change without centering it upon the people who need the change. And so what we did in San Francisco is really work with a group of LGBTQ people who helped us not only frame the questions, but really talked a lot about, how we fit them into the general demographic questions that we ask, and normalize them in that way and socialize them in that way. We also did a lot of work to train not only our providers and our staff on why this is important and what you do ultimately with the data, but we also did training in the senior centers with the meals programs. We sent some flyers out. We did all sorts of things to try to engage our larger community of older adults as well, and to really help, make them feel comfortable to come forward if they wanted to share the SOGI data. And, not everybody does, but the people who really need it will. And ultimately, as people come forth and are able to be out with that information, we'll see, we've certainly seen a huge uptick since we first started this process. And that's kind of how it happens. It happened when we started asking questions about race and ethnicity, and it will happen in the same way. So it's a process, and it takes some time.
Great, thank you for the question. For us, our situation was a little more unique because we have our tribal community members, and so I think having that tribal representation within the organization, the co-program does such a great, wonderful job with extending, the knowledge that we have and sharing that with our community members. And so I think really the COPE organization is focused more on, having that native component. So a lot of our staff are Native American, and, generally with our Navajo population, they do feel a sense of hesitancy giving some of their data collections to healthcare providers. But, I think having that Native American representation within that really helps provide some level of assurance to our participants. And so, language barriers, culturally tailored materials, and, things like that, we've had to incorporate and integrate into the care so that they're more considerate of, what sort of materials they have that are available for our participants, and it's not like they're given things that are, things that they don't understand. We've had to break it down for them in a way that it makes sense for them and that they feel comfortable and they're able to really understand, how this impacts them, because a lot of the information that we're given, guidelines from nutrition and things like that are tailored to outside populations that don't really fit into, the unique circumstances that tribal communities face. And so I think really understanding the barriers that we provide, or the barriers that are provided, with some of the information that we have, we've really helped to tailor it around, what's unique into our communities. And that's where a lot of the community members, the connections that we have with our community, we take their suggestions that they have, if there's a development of, education material and things like that, we try to integrate that into the care that, our program provides to, the providers and things like that, and really just educating them about tribal practices and, just having them understand more so about, how our people view things and how communication, sometimes they view things differently. And so I think, like most of the other people on this panel, just really tailoring the program and the data collection, the translation, really tailoring it to the population that we work with. That way it makes better sense for them. They understand it better, and they're more comfortable because they feel like what we're doing really is geared towards them. And, it's really created for them to be able to, overcome some of the challenges that they face, or, some of the issues that they face within the health system.
Yeah, definitely. And, we talked about policy throughout this event, and particularly I know Naomi and Andy, you've brought really amazing points around policy, but a question from audience is, in the absence of national standards or policy in this area, what can individual states do to lead on this issue and learn lessons from the pandemic? Andy, do you have any thoughts on that one?
Yeah, look, I mean, everybody can do something. And if everybody waits for everybody else in order to do their job, we'll never get anywhere. So, California is, I think, just in this call alone, put out several ways in which they're leading. I know other states are doing the similar things. So, I think you just have to start, become a model, and tell everyone what you're doing. Work with CMS, work with private payers, work with hospital systems, work with, obviously, foundationally with the community groups. And do your piece. The healthcare system's too big. We all need to be citizens of the whole rather than masters of our little world.
I completely agree. And, just also a plug, check out in your state if there are coalitions already working on these issues, doing advocacy and trying to pass progressive legislation. I know in the state of California, we've talked about interoperability and health information exchanges today, and their importance of advancing health equity. In California, there's the Connecting for Better Health Coalition that's focused on getting interoperability HIE legislation passed with equity in mind. So check out the chat for information on that. But yeah.
Hi, sorry. I just wanted to tag along to on what Andy said. I definitely agree about his point about engaging states, making sure that states are engaging a broad subset of stakeholders, so community-based organizations, health plans, providers, hospital systems, across, as from a association perspective, I'd be remiss if I didn't say I think it is important that states come together to support efforts to establish multi-stakeholder efforts to establish standardized collection, so we don't end up in a system where there's 50 plus different continue with 50 plus different regulations around collection and use. I think that, for, thinking broadly around our country, I think it is important that we have national standards, a collection of best practices from states, right? So lessons from the states are succeeding in those perspectives and on these issues. So really, kind of a push for broad stakeholder engagement, but also considering participating across states so that we have a collection of, standards and as well best practices for, states can learn from one another, and making sure that, we're working collectively and not just one on.
Yeah. And Dr. Hernandez, question for you around community-based organizations. So what suggestions do you have to use data given limited resources at community-based organizations and research abilities, but strong access to impacted community members?
Yeah, thank you for that. It's a really important question. And, what I would say is, there are a number of different models for how you can address this, because I think what you really do want to do is bring research capabilities to information and knowledge that's already innately known within communities that we're trying to reach. A couple of examples of that, many of our healthcare delivery systems here in California, the University of California has a number of centers that are addressing health disparities. Just as a concrete example, a board member of mine at UC Davis runs a health disparities program. And they partnered with a bunch of not-for-profit organizations working in Solano County as a partnership between research and nonprofits that were trying to address a number of health disparities, particularly working with folks that work in agriculture, where it's really hard to collect information. And yet community-based organizations had that information and really was able to connect to a research capability that exists within academic institutions. Also, all of our hospitals have community benefits programs, and the connection of not-for-profits to those community-based organizations connecting into those community benefit programs can also tap research arms and capabilities that brings, again, the innate knowledge of community with research capability in a way that's quite useful. I'll give you an anecdote that will date me quite a bit. But during the HIV epidemic, for example, in San Francisco, a lot of the research that was originally done around HIV, around AIDS education, around early use of antiretrovirals was done through community-based researchers. And so these were physicians that were serving large populations of HIV folks who then partnered with not-for-profits and communities to build a research base in a community-based setting. And I think we have an opportunity to do that today. We have a lot of small practices, physicians that are working 2 people and 3 people, but serve a particular niche with respect to a Korean community or a Chinese-speaking community. And we need to make sure that those physicians are also part of the community-based and research agenda so that those folks who are also have rich amount of information and data that can inform how we allocate resources, those connections really need to be met. So those are just a couple of examples of where we have seen really the assets of community knowledge with the assets of research capabilities come together. And you see now health equity programs really in most all of our delivery system. And I think the goal there is to have our community-based organizations that have been serving this community for a long time to be able to connect to that capacity that exists within the community.
How can we promote public and private partnership collaborations with data integrations and really, move faster, but also have that really authentic impact? I think almost all of you can mention this. So really this is open to the group, whoever would like to answer.
Yeah, I'd like to also twist this conversation in another direction, as I often like to spark thinking here, is turn the mirror on ourselves. And what do I mean by that? Is I think in the future, if you believe that we can reach that patient and consumer, that patient consumer will also want to know who in the healthcare system with a capital H best can serve my community, and that I will want to either be my payer or be my provider over time. So in the past, we've talked about like narrow networks. We actually believe at Define there are going to be branded networks. And what I mean by that is turning the mirror to ourselves and also thinking about the data we need from providers and payers and others that say, do you really understand this community? Are you the right network player from when we hand off from a direct to consumer front door of healthcare all the way back into the ecosystem? You can imagine, we believe we're going to get data from providers to say, have you been trained in DEI? Have you been doing these things to create a network that's branded for this community and kind of have the seal of approval, if you will? So I just wanted to introduce that data layer as well, because we've been talking a lot about the consumer, but reflect it back upon, I'll say, us as those people from the healthcare system, because I think that day is coming too. We can then use that to also up level, I believe, the healthcare ecosystem and their ability to serve these communities as well.
Yeah, Shireen, let me just build on your question as well, and I'm sure Lynn and Andy will also have something to say on this point. But I also think we have entrepreneurs who have great ideas about companies that can and should be built to address a number of these social determinants of health and programs that just have a hard time getting access to capital. And so I think one of the things that we're also trying to do is reach into early entrepreneurs and make sure they get the mentorship, the capital, the introduction, so that they can get the kind of funding that Lynn does and that Andy's firm also does. And so I think that's an area for, I think, unlimited growth opportunities. We've got a program now focused on identifying those early entrepreneurs, getting them seed funding with a lot of support for our board, sort of saying, yeah, all of these companies won't make it big and won't scale, but a lot of them also will. And I think finding entrepreneurs and those folks from communities who have innovative solutions to many of the things that we're talking about really need to get into an ability where they can be funded and those companies' ideas can be accelerated and supported.
Thank you all so much, panelists, for this was such a rich discussion, and really value your time in being here. And again, you all are very important people, and the fact that you took 90 minutes to talk about this topic, it really just shows the importance and what folks are doing in diverse sectors to make this move.
Thank you for organizing this. Appreciate the opportunity.
Thank you, everybody. Nice to see you all.
Thank you.
Thank you.